Hello, good evening, students. Welcome to the class. The class is on arterial disorder. Please let me know if I'm audible. You can give a thumbs up sign so that I can proceed with the class. So before starting the class, I must tell you about the Unacademy subscription. There are basically two types. One is plus subscription, where you will get Unacademy live classes, and there are almost daily live classes. There may be multiple live classes also per day, and there is a structured schedule. If you are preparing for 2021 NEET PG, or if you are preparing for INICT, or if you are preparing for NEET PG 2022, then you can take this subscription. Okay, there are live tests and quizzes also, and there is one more subscription apart from that, that is known as iconic subscription. Here you can take benefit of two. Okay, so in this subscription you'll get all those benefits that you are getting in Unacademy, like live classes, structured schedule, live tests and quizzes, that you will get in iconic subscription also. Apart from that, you will get a prep ladder, question bank, prep ladder, handwritten notes, video lectures and revision courses from prep ladder. So few educators are on Unacademy and few are on prep ladder, so you'll get the benefit of both in iconic subscription. So obviously this is a better, where you'll get these two platforms, a best learning platform, you'll get a iconic subscription. Okay, now students, those who are preparing for 2021 NEET PG, they can attend free live tests every day at 8 o'clock. And those who are preparing, those who are doing internship, or those who are preparing for 2022 NEET PG, then they can attend live tests at 9 p.m. Both are free, you can attend it. Okay, you just have to download the Unacademy app. There are other special classes also that are absolutely free. You don't have to take any subscription. They are special live classes on Unacademy. You just have to go to Play Store, download the Unacademy app, and you can take the benefit. Okay, many educators, many teachers are there on Unacademy, and you can take the subscription that I was talking about. Whether you are taking plus subscription or you are taking iconic subscription, you can take accordingly. Like if you are preparing for 6 months, then if you are preparing for 12 months or 18 months, according to you, you can take the plan. And obviously you can use surgery 10 code or Dr Animesh 10 code to get 10% off. Let's start the class, students. That is arterial disorder. Please let me know if I'm audible. Yes, so first of all, I would like to discuss arterial occlusive disease. See, what are the causes of arterial occlusive disease? There are certain common causes and there are certain rare causes. In common causes, one is atherosclerosis. This is the most common cause of peripheral arterial disease. Okay, atherosclerosis. Other common causes are Buerger's disease, Takayasu arthritis, SLE, post-traumatic arthritis, radiation arthritis. Radiation arthritis is a type of obliterative endarthritis. There are certain rare causes of arterial occlusive disease, like external compression, popliteal entrapment, or thoracic outlet syndrome. They are very important topics. Thoracic outlet syndrome is again a huge topic. It's a very, very important. Then retroperitoneal fibrosis, coarctation of aorta, cystic medial necrosis, or fibromuscular dysplasia. These are rare causes that can cause occlusion. Okay. Now, as we have discussed atherosclerosis and Buerger's, let's discuss few points. Atherosclerosis mostly occur after 40 years of age. Most commonly it is seen in 6th and 7th decade. The risk factors are smoking, diabetes, hypertension, age, and hyperlipidemia. Few of them are modifiable risk factors, few of them are non-modifiable risk factors. So in atherosclerosis, actually it causes occlusion of large and medium sized vessels. Okay, remember that In atherosclerosis, there is occlusion of large and medium sized vessels. Small sized vessels are not involved in atherosclerosis. And in atherosclerosis, symptoms predominantly seen in lower limb. Okay, now what is the difference between atherosclerosis and Buerger's disease? Buerger's disease usually occur in younger age group, less than 40 years of age, male smokers. It involves medium and small sized vessels. So it can involve small vessels like tibial, plantar, radial arteries. Plantar means distal vessels it can involve. And the symptoms are seen both in upper as well as in lower limbs. Mostly lower limbs are involved. Now there is a term known as embolic occlusion, where an embolus is actually a detached thrombus. It can come from any vessel or it can come from heart. The most common source of embolus is left atrium in atrial fibrillation. Now if a patient is having atrial fibrillation, there is a risk of embolus, and that embolus can lodge anywhere and can cause occlusion anywhere in any organ throughout the body. And depending upon the occlusion, depending upon the site of embolus getting occluded, the patient can have symptoms based on that. So the most common source of embolus is left atrium in atrial fibrillation. Then another source is mural thrombus following myocardial infarction. Aneurysm, thrombi formed on atherosclerotic plaques are other sources of embolus. Okay, now if embolus gets lodged in other parts of the body like other organs, it can cause ischemic symptoms. Like if it go into brain, if in brain, in any vessels in the brain, it gets occluded, it can lead to ischemic attack, that is known as TIA, transient ischemic attack, or stroke. In eye, in retina, it can cause amaurosis fugax. In mesenteric vessel, it can cause gangrene of the loop of intestine. Mesenteric vessels, if they are involved, like if embolus is getting lodged into the mesenteric vessel, it can cause gangrene. So it's a big topic. Embolus occluding the mesenteric vessels is altogether a huge topic. I have discussed on Unacademy in the classes, and where I have discussed about these intestine disorders. Okay, there I have discussed all the types of occlusion in the mesenteric vessels: arterial occlusive disease, venous occlusive disease, embolus, non-occlusive embolus, everything we have discussed. Okay, so now if embolus can go and lodge inside spleen, it can cause local pain. In kidney, it can cause loin pain or hematuria. And in leg, anywhere in the vessel in the leg, if it is lodged, it can lead to P's, 5 P's. What are those 5 P's? Pain is the most common symptom. Okay, then there can be pallor. Second P is pallor. Third P is paralysis, pulselessness, and paresthesia. One more P is added, that is known as poikilothermia, that is added in 5 P's. Okay, so usually embolic arterial occlusion is actually an emergency situation. It requires immediate treatment. If it is not treated, the patient can have gangrene formation, and ultimately you have to remove the part. So to save the organ or to save the part, it should be treated in emergency. Leg is most commonly affected, and movement becomes progressively more difficult and sensation is lost. Pulse are absent distally, but femoral pulse may be palpable. Okay, and diagnosis is mostly made clinically. Now you can see these are the features of arterial occlusive disease. On the left side of the left leg, these features are visible. The leg is atrophic, thin. There will be lack of hair, then shiny skin, brittle nail, absent pulse, cold, and associated with gangrene. or there can be pregangrenous changes. So these features are easily visible on the affected side. Okay, so remember all these features. These are features of arterial occlusive disease. Now we're coming on to the treatment. So we give IV 5000 units of heparin immediately. It reduces the extension of thrombus and maintains the patency of the vessel. So heparin is given IV 5000 units immediately. If embolus is present in the limb vessels, then you can go for embolectomy or thrombolysis. To decrease or to reduce the plasma viscosity, we can use dextran 40 or 70. It can there can be temporary improvement due to that. Okay, low molecular weight dextran can also be used. It causes hemodilution, it reduces the viscosity and improves the microcirculation. Then all these in the treatment, intraarterial injections are more effective. Now when we have to go for revascularization, so revascularization is a procedure, okay, to reverse to maintain the blood flow in the limb. So if patient is having disabling claudication, actually there is a grade of claudication. Okay, so if patient is having disabling claudication, if there is pain while at rest also there is pain, then tissue loss if it is there, then we have to go for revascularization procedures. There are other techniques like bypass surgery and arterectomy, where in bypass we can use grafts. There are synthetic grafts, there are biological grafts that we can use. Like synthetics graft are PTFE or Dacron graft that we can use. These are autogenous reverse saphenous vein graft. Reverse saphenous vein graft can be used, that is biological, and synthetic grafts can be used. So this is bypass surgery that can be done in these patients. And another is endovascular techniques, where we can use balloon angioplasty or stent angioplasty, and we can go just inside the vessel, we can go and dilate the vessel, that is balloon angioplasty, or stent is placed to maintain the patency of the vessel, that is stent angioplasty. Or if there is gangrene formation, then amputation is done. So these are procedure for revascularization. It will save the limb. Okay, now Buerger's disease is also okay. I'm sorry, there is some problem with the connection. Okay, so I was discussing Buerger's disease. It's also known as thromboangiitis obliterans. It's a segmental inflammatory disorder. It affects small and medium-sized arteries, as we have already discussed, and it affects both upper and lower extremities, both upper and lower limb. There is not only involvement of arteries, but also there is inflammation in the veins and nerves. So Buerger's disease involves all the three structures: veins, arteries and nerves, and it is strongly associated with smoking. It is seen in male smokers of younger age group. It is not seen in non-smokers and females. There is a triad that is present in Buerger's disease. What are the 3 points? Raynaud's phenomena, it is seen in Buerger's disease. And there is intermittent claudication. I'm going to discuss intermittent claudication soon. And then third point in this Buerger's disease is migratory superficial vein thrombophlebitis. So these 3 points are seen in patients of Buerger's disease. Now initially patient presents with pain or claudication in foot, leg, arm and hand, and eventually it progresses and there will be pain at rest, and then further when it gets severe there will be formation of ulcers on toes, feet and fingers. Now there is a classification for intermittent, that is known as for intermittent claudication. Okay, that is known as Boyd classification. So there are basically 4 grades. In grade 1, patient walks for a distance, pain started, he continues to walk and then pain disappears. In grade 2, patient walks for a distance, pain started, and then when he continues to walk, pain remains, and then he starts limping. In grade 3, while walking, pain started and patient compels to take rest, and in grade 4 there is pain at rest. Okay, and pain at rest is actually a indication for revascularization procedure. This is Boyd classification. Now coming on to the investigation. See, on histopathology in Buerger's disease, you will get segmental it's a segmental inflammatory disorder. So there is acute and segmental, acute and chronic vasculitis, means vessels are involved in segments, and there will be thrombosis of lumen with organization and recanalization. Okay, recanalization mostly seen in chronic cases. Thrombus that is present has micro abscesses, and there is involvement of all the three structures: vein, artery and nerve. In duplex scan, where you'll go for ultrasound and Doppler, which is a non-invasive, it can visualize the vessels, stenosis or plaque which is present. It can also detect the flow. It can detect the flow if it is occurring in normal direction, or if there is a biphasic flow, it is not occurring in normal, it is coming reverse, there is reversed flow. That can be detected in duplex scan. Duplex scan is good for infrainguinal vessels. Abdominal vessels are obscured by bowel gases. It is good for infrainguinal, means below the thigh region. Now third investigation is angiography. Be done. There are basically different types of angiography: CT angiography, MR angiography and catheter angiography. An angiography of all the 4 limbs can be done. So if symptom is present in one limb, angiography of all the 4 limbs are done, just to check if the disease involvement is there in other limbs or not. So disease is confined to distal circulation. It usually involves medium and small sized vessels, and usually infrapopliteal and distal to brachial arteries vessels are involved. Okay, now as I have told you, in chronic cases there can be formation of collaterals. So as it is a segmental occlusion occurs, occlusions are segmental and show skip lesions with extensive collateralization. Collateralization is not seen in acute conditions, it is seen in chronic condition when there is development of collaterals, and these are known as corkscrew collaterals. Corkscrew collaterals are seen in Buerger's disease. Now coming on to the treatment. So first is stop smoking, abstinence from smoking. Then to relieve the pain and formation of ulcers, means to cope up with complication, we can do sympathectomy. Then medial transposition, and if there is gangrene formation, then amputation can be done. Revascularization procedures we have already discussed. It is rarely feasible because there is involvement of small and medium sized vessel. Usually revascularization is done for when large vessels are involved. For small vessels it cannot be done. Second problem with revascularization is this disease is segmental. There are skip lesions. So if there is one lesion present, then you can just bypass or you can do revascularization. But if there are multiple skip lesions, you cannot do bypass or revascularization for all those lesions. Okay, again that is the main second problem. And then third is absence of distal target vessels for bypass. So these are main problem with surgery of Buerger's disease. Now what is arterial ulcers? Mostly these arterial ulcers occur in the distal ends of the limb, on the lateral surface of ankle or distal digits. It is caused due to lack of blood flow to the capillary bed, and in diabetics, in patient with diabetes, there is micro or macroangiopathy, where there is endothelial dysfunction. That is the main pathophysiology of development of arterial ulcer. There is endothelial dysfunction, and that is seen in diabetic patients. Now ischemic time, direct one-liner can be asked. Ischemic time for digit is how many hours? 8 hours, and for extremities it is 4 to 6 hours. Now what are the features of arterial ulcers, students? One, there is a punched out appearance. These ulcers are very painful. and peripheral pulses are obviously not palpable because it is due to occlusion of arterial vessels, arteries, and it is associated with the skin changes. The skin changes that we have just discussed, I have shown you the pictures, so skin changes can be associated. So pulse is absent, not palpable, ulcer is painful, there is a punched out appearance, and skin changes. Okay, now the investigation we have discussed, the arterial Doppler and pulse volume recording can be done if there is a formation of arterial ulcer. Just to detect which artery is involved, we can go for these investigations, and blood flow in those vessels should be assessed. X-ray can be done to rule out osteomyelitis. What is the treatment of arterial ulcer? See, regular dressing is obviously must, it is important, but arterial ulcer, until and unless the flow in that offending vessel is not maintained, the ulcer will never heal. So obviously you have to do regular dressing, wound dressing of that ulcer is important, but apart from that, revascularization surgeries to restore the blood flow in the offending vessel is must. The vessels should be revascularized, the blood flow should be there, then only arterial ulcer will heal. That is the key point. Okay, antibiotics, debridement, wound dressing will obviously it is important to avoid infections. Okay, but if you want to heal, if you want arterial ulcer to heal, you have to go for revascularization procedures, then only it will heal. Now next condition is arteriovenous fistulas. It's an abnormal communication. It can be congenital or it can be acquired. Some acquired conditions are iatrogenic, which are done like in hemodialysis patients. We make arteriovenous fistulas. These are surgically created fistulas for hemodialysis, and there are certain congenital fistulas, arteriovenous fistulas. Actually, most common type is congenital AVF. Congenital AVF is the most common type, and this congenital AVF can be of two types further: microscopic type and macroscopic type. The example of microscopic congenital arteriovenous fistula is Klippel-Trenaunay syndrome, and macroscopic congenital arteriovenous fistula is Parkes-Weber syndrome. Direct one-liner you will get. So 3 different MCQ: microscopic congenital arteriovenous fistula, macroscopic congenital, most common type of arteriovenous fistula. Okay, now if they will mention what is the cause of, or what is the most common cause of acquired arteriovenous fistula, then it will be penetrating trauma. Penetrating trauma is the most common cause of acquired arteriovenous fistulas, and surgically created fistulas, arteriovenous fistulas for hemodialysis is the second most common cause for acquired arteriovenous fistulas. Now acquired AVF can occur due to penetrating trauma, it can occur due to surgically created fistulas for hemodialysis, it can be due to rupture of aneurysm into the vein. If there is aneurysm in the vessel, it can rupture into vein, then there will be formation of fistula. And fourth is iatrogenic. Iatrogenic means they are not surgically created, they are formed by some surgical error. In arteriovenous fistula, what happens? Actually, there is a communication between the veins and the artery. So arteries are usually thick walled. So similarly, if there will be connection between artery and vein, so veins will be arterialized, means they becomes dilated, tortuous, and they get thick walled. Okay, now how this arteriovenous fistula presents? There will be a pulsatile swelling, and on palpation there will be a thrill. On auscultation there will be a bruit, and bruit will be continuous. Now there is an important sign known as Nicola-Doni sign or Branham sign. What is that? On pressure on arterial Pressure on artery proximal to the fistula causes swelling to diminish in size, thrill or buoy to stop or cease, and pulse rate to fall, and pulse pressure returns to normal. Okay, so this is Nicola-Doni. See, if there is an artery and there is a fistula and then there is a vein, if you will, the blood flow is from the artery, then fistula, then vein. So if you will just block the artery, what will happen? There is a swelling due to that fistula, that swelling will subside. The thrill, whatever was present due to that fistula, everything will diminish. Okay, so this is Nicola-Doni or Branham sign. Direct MCQ you may get, students, like Nicola-Doni sign is seen in direct AVF. Okay, now duplex scan and angiography will confirm the diagnosis of AVF. The treatment of AVF is elastic stocking. You can do sclerotherapy, or you can go for ligation, or laser for bleeding superficial angiomas, and surgical separations and lateral repair of both artery and vein. So these are treatment options that we can go for AVF. Other procedures are endovascular repair, where stented graft inserted into the artery to exclude the fistula tract. Embolization, excision surgery can be done. There are different types of surgically created fistula. Basically, we do it for hemodialysis. So if there is a connection, if you create a fistula between radial artery and cephalic vein, it is known as breccia semino. Okay, this is the name given for a surgically created fistula for hemodialysis. If you are connecting, direct MCQ may get, it's a fistula between radial artery and cephalic vein. What is Feinberg fistula? It's a connection between radial artery and basilic vein. What is snuff box fistula? The fistula or connection between the posterior branch of radial artery and cephalic vein. Okay, so just remember the names, they can be asked. Just one-liner type question can be asked related to these. Now students, let's move on to another important disease disorder, thoracic outlet compression syndrome. It's a neurovascular, actually due to compression of vessels and nerves, actually neurovascular bundles, there is formation, there is presence of symptoms. These symptoms are neurovascular symptoms, mostly seen in upper extremities due to pressure over the neurovascular bundles. Now if there is pressure on neurovascular bundle, that pressure will be on subclavian vessel, nerves of brachial plexus in the region of thoracic inlet, and based on these compression, subclavian vessel and brachial plexus compression, patient will produce symptoms. Okay, so this is divided into two types. If there is occlusion in the vessel, suppose if subclavian vessel or any vein is involved, that is known as vascular form. Vascular symptoms are less commonly seen. Mostly patient present with neurogenic symptoms, neurogenic forms. 90% of the patients of thoracic outlet syndrome present with compression due to branches of brachial plexus, that is neurogenic form. And compression is dynamic, best evaluated by provocative tests. So there are many provocative tests, many, almost 7-8 provocative tests are there, just to know just to know the neurogenic symptoms in cases of thoracic outlet syndrome. Okay, and this condition is mostly seen in middle-aged females. Now there of compression in thoracic outlet syndrome. The compression is due to some conditions. What are those conditions? See, in the thoracic outlet syndrome, there is compression of neurovascular structures, and that compression is due to many reasons. It can be due to cervical rib, it can be due to long transverse process of C7 vertebra, it can actually occlude the brachial plexus and the subclavian vessels, and third is abnormal first rib, that can also compress. deep bundle, neurovascular bundle. Then if there is any presence of fibrous band or ligament, or some due to trauma there is collection of hematoma or bone dislocation or fracture clavicle, these can also be the neurovascular bundles. So if there is any presence of neoplasm tumor, that can also compress. So these are causes. Other causes are osteoarthritis, exostosis. Then there is a scalenus muscle, and if it is abnormally insertion is there, or if it gets hypertrophied, then it can lead to thoracic outlet syndrome. And poor posture, obesity, and pregnancy are other causes of compression. Now I have told you symptoms are mostly related to neurogenic or compression of nerves. So most common nerve affected is ulnar nerve. The root is C8T1. What happens if the ulnar nerve is compressed? It is associated with motor weakness and atrophy of hypothenar. This is thenar, this is hypothenar, so there will be a weakness and atrophy of hypothenar and interosseous muscle. There will be weakness in the forearm and hand. Okay, it is due to the compression of ulnar nerve only. Now pain and paresthesia along the medial aspect of arm, hand, fifth finger and medial aspect of the fourth finger can also be seen. Okay, and there is occipital headache. It is due to tight scalenus muscle. Now if patient is having arterial symptom, then what will happen? 5 P's I have told you that will present. Then patient will have fatigue, weakness in the limb, coldness, pain, paresthesia, upper limb claudication can occur. Okay, all those features that we have discussed in arterial occlusive disorders that can occur. There can be presence of Raynaud's phenomena, then there can be formation of ischemic changes that can occur here. Okay, and if veins are compressed, then there will be development of edema, venous distension, collateral formation, cyanosis. There can be thrombosis inside the vein, inside the subclavian vein or axillary vein, and a syndrome that is known as Paget-Von Schroeder syndrome, which is also seen when in thoracic outlet syndrome veins are compressed. So you should know what patient of thoracic outlet syndrome can present with varieties of symptoms. Based on neurogenic compression, based on arterial or venous compression, the patient will produce symptoms. So these are symptoms of TOS. Now how to detect, how to test the compression, or how to test the thoracic outlets if there is actually compression, and how you will test. These are provocative tests, means you will ask the patient to do certain maneuvers and symptom will increase. Okay, so I have just discussed the names here. Actually you should know each and every detail about these tests. There is very less time, so that is why I'm not able to discuss all these tests here. On Unacademy classes I have discussed all, so I have taken special classes also, so I think they are free. You can go and attend the Unacademy classes, they are free. You can I have discussed all these tests in arterial disorders. Okay, so you can just go through these tests. They are very important. In fact, in exam you may get a picture of a doctor just examining a patient, and they can ask you image based question. They can ask you which test is this. A direct question you may get from these provocative tests. They are very important. There is Addison test, then modified Addison test, then you should remember the other names also: costoclavicular test, or military position test, or Halstead test. They are one and same thing. Then hyperabduction test, also known as Wright test. See, Addison test is also known as Scalene test. And fifth is Roos test. Roos test is also known as arm claudication test or elevated arm stress test. It is done like this. Okay, so you should know all these tests. Now moving on to the investigation of thoracic outlet syndrome. So chest x-ray, cervical chest x-ray is important to detect if there is any abnormality in the bony structures or not, whether there is cervical rib, or whether there is long transverse process of C7, or whether if there is a trauma, then you have to detect whether there is clavicle fracture or not, or whether there is any rib fracture or not. Okay, so you can detect on chest x-ray. Ultrasound and color Doppler is important to detect any stenosis or occlusion in the vessel. CT scan, MRI, cervical myelography, angiography are all important. Nerve conduction study, electromyography are all important. Based on the symptoms, you can go for investigations. Okay. Now coming on to the treatment. See, there are conservative treatment, there are surgical treatment. So first we will discuss conservative management. What are the conservative? Postural improving exercises. So you'll ask the patient to exercise. Postural improving exercises. Then breathing, there are certain breathing exercises. Aggravating activities, all those things that aggravate the symptom should be avoided. Physiotherapy, behavior modification, muscle stretching and strengthening exercises. Then if there is pain, then analgesics, muscle relaxants and antidepressants can be used. Now student, coming on to procedures. First is botulinum toxin or Botox. Okay, it relieves the symptom temporarily. It takes 2 weeks to work but lasts for 3 months, and injection is given under ultrasound electromyographic guidance, and lidocaine scalene muscle injection can be used if conservative treatment fails. So after conservative management, you can give lidocaine scalene muscle injection, you can use botulinum toxin, or you can go for surgical intervention. Surgical intervention in thoracic outlet syndrome is done when conservative management fails, when there is progression of symptoms, sensory symptoms and motor symptoms, when there is presence of excessively prolonged ulnar and medial nerve conduction velocities, narrowing or occlusion of subclavian artery, and thrombosis of axillary and subclavian vein. So if it is there in TOS, surgery is advised. Now, what surgery will do? Anyone? What surgery we do in thoracic outlet syndrome? Anyone? So operation for thoracic outlet syndrome is, first remember FRRS. What is that? First rib resection and anterior scalenectomy. It is seen that when we resect the first rib and when we resect the anterior scalenus muscle, most of the patient gets relieved due to this syndrome. Okay, so complete removal of first rib can be done. In FRRS, we do complete removal of first rib with division of scalenus anterior and medius muscle. If cervical rib is present, then it should be resected, and usually we take a transaxillary or supraclavicular approach. If there is a presence of large aneurysm or thrombus present in the subclavian artery, graft reconstruction is advised, and if there is thrombus present in the subclavian vein, then thrombolytics, anticoagulants, embolectomy or surgical decompression are advised. Okay. Now next topic is aortic dissection. Aortic dissection is actually a circumferential or transverse tear of the intima, directly exposing the diseased medial layer to intraluminal blood. What happens then? Blood penetrates into the diseased medial layer, and then it can go two sides. It can either rupture the outer wall and go outside, or it can it can go back to the lumen. Okay, when the blood penetrates the diseased medial layer, it cleaves the media longitudinally, and then it can either rupture the adventitia or outer wall and go outside, or it can enter into the lumen. Okay, so there, what happens there will be development of false lumen. For a short distance, there will be the formation of false lumen. The most common site of aortic dissection is right lateral wall. Very important. This question was already asked in your exam. You may get it again repeat. Okay, so most common site of aortic dissection is right lateral wall of ascending aorta. If it is not given in your option, mark descending thoracic aorta. It mostly occur in 6th and 7th decade, and males are more commonly affected. What are the predisposing factors of aortic dissection? systemic hypertension, cystic medial necrosis, Marfan syndrome, Ehlers-Danlos syndrome, bicuspid aortic wall, Takayasu arteritis, giant cell arteritis, coarctation of aorta, history of aortic trauma, and third trimester of pregnancy. These all are predisposing factors, means they increases the risk of aortic dissection. If patient is already having these, you should also think of aortic dissection. Okay, now there are types, grades of aortic. Actually, this is a classification for aortic dissection, and it is known as, there are two most commonly used is DeBakey classification and one is Stanford classification. So DeBakey classification is divided into type 1, 2 and 3. What happens in type 1? The ascending aorta, arch of aorta and descending aorta is involved, means ascending, descending both involved in aortic dissection. Whereas in type 2 only ascending aorta is involved, and in type 3 only descending aorta is involved. Now can anyone tell me which of the type is the most common? Type 1, type 2, type 3. Which type is most common? Okay, so this patient with aortic dissection present with sudden onset pain, which is severe, tearing, intractable chest pain. Yes, there will be pain, and pain will be localized to front or back of the chest or interscapular region, and it can migrate with propagation of dissection. There can be symptoms like sweating, weakness, dyspnea and syncope. There are certain signs that is seen in aortic dissection patients. First, the patient is hypertensive and then land up in hypotension, shock. There will be loss of pulses, or there can be bounding pulses, then wide pulse pressure, diastolic murmur radiating along the right sternal border, aortic regurgitation, pulmonary edema, hemiplegia, hemianesthesia due to carotid artery obstruction, and paraplegia due to spinal cord ischemia. So these are signs that are seen in patients of aortic dissection. Remember all these signs, they are very, very important. Now, see, ascending aorta is most commonly involved. 65% times the dissection occurs in the ascending aorta. Okay, descending aorta is 20%, arch of aorta 10%, and abdominal aorta is 5%. Most common is ascending aorta. Now, investigation may ECG you will get non-specific STT wave changes. On chest X-ray, I'll show you. This is the chest X-ray. You will get a aortic knob. Okay, are you able to appreciate the aortic knob that is present? There is aortic knob which is seen in aortic dissection. Okay, there is enlarged aortic knob. Then there is, which is also known as eggshell sign. Then there is a widened superior mediastinum. Okay, you can see the superior mediastinum is widened due to this aortic knob only, and there can be presence of left side pleural effusion, which is serosanguinous. On CT scan, there can be severity of you can detect the severity of dissection. MRI is the gold standard for diagnosis. Transesophageal echocardiography is also helpful in aortic dissection. Coming on to another investigation that is known as aortography. Now, in aortography, we can detect branch vessels or coronary artery involvement. Okay, that is why aortography is important in aortic dissection. You can see coronary artery involvement, you can see any other branch vessels that can be involved, and in aortography you can detect a double barrel aorta. You can see for double barrel aorta. When both true and false lumen are seen, true lumen is the lumen of the vessel, and false lumen is when blood flow into the diseased media, that is the false lumen. So actually false lumen and true lumen can be seen in aortography, that is known as double barrel aorta. Direct MCQ may get double barrel aorta on aortography is seen in which condition? It's actually a true and false lumen seen in aortic dissection. Okay, you can also get certain image like this aortography, and they can ask you direct diagnosis, or they can ask you which sign is this. So it's a double barrel aorta or it's a aortic dissection. image in aortography. Okay, you just remember the image, students, because nowadays image based questions are more commonly asked. Now coming on to the treatment, aortic dissection means we have to reduce the blood pressure. There is patient present with hypertension, we have to reduce the systolic blood pressure, we have to reduce the heart rate, and we have to halt the progression of the disease. Now what is the indication of medical therapy? When you will give medical therapy in patients of aortic dissection? If there is an uncomplicated distal dissection, then we can give, if it's a type B DeBakey classification, type B, then we can give medical therapy. If it's a stable arch dissection, then we can give. If it's a stable chronic dissection, then we can give. Means in uncomplicated and stable conditions only we give medical therapy. In unstable and complicated cases we go for surgery. So what are the treatment? IV beta blockers like labetalol and esmolol can be used. When beta blockers are contraindicated, then we can use calcium channel blockers. Morphine can be used for pain relief, and sodium nitroprusside can be used to reduce the BP. Okay. Now as we have discussed indication of medical therapy, so indication of surgical therapy mein there is acute proximal dissection. When there is acute proximal dissection, we can have to go for surgery. It's an emergency situation. Or complicated or unstable dissection, or impending to rupture or rupture, or dissection in Marfan syndrome is indication for surgical therapy. Or descending thoracic aorta, when the diameter is more than 5.5 centimeter, then we have to go for surgery. It's an important indication. Descending, I'm talking only about descending thoracic aorta. When dissection in the descending thoracic aorta is more than 5.5 centimeter, it's an indication for surgery. What we do? We remove the damaged segment of aorta, obliterate the false lumen by suturing the proximal segment. Now type A are mostly open surgical repair, and type B are done. Type B is usually done. Type B may we do endovascular aortic dissection repair and endovascular fenestration. Okay, so remember the indication, remember the type of surgery we do, remember the indication of both medical and surgical therapies. Okay, so this is actually thoracic endovascular aortic repair, also known as TEVAR. Okay, where we use endovascular technique to repair the aorta. We can place a stent, okay, at the site of dissection. The next topic is aneurysm. Aneurysm is permanent and irreversible localized sac or dilatation of the blood vessel. Now you must know the difference between aneurysm and dissection. In dissection, there was diseased media, and blood was going into the diseased media, making a false lumen, and then going back or rupturing the adventitia. But in aneurysm, what happens? There is just dilatation. It can enlarge due to high pressure, produce complication by compressing surrounding structures. Second most common disease of aorta. It's the second most common disease of aorta after atherosclerosis, and diameter is increased in aneurysm by more than 50%. In abdominal aortic aneurysm, diameter is more than 3 cm in males, and in female it is more than 2.6 cm. Now few one-liners. The most common location or most common site for aortic for aneurysm is aorta, then iliac vessel, then popliteal, and then femoral. The most common site of extracranial aortic aneurysm is infrarenal aorta. Remember the line, exact line, remember that. Okay, most common site of extracranial arterial aneurysm is infrarenal aorta. Most common site of peripheral aneurysm is popliteal aneurysm, and degenerative aneurysm occur most commonly in abdominal aorta. 90% of the abdominal aortic aneurysm are degenerative aneurysm, and most important predicting factor of rupture is width. The more the width of the aneurysm, higher chances of rupture. And Joan Parodi gives the technique that is known as endovascular aortic aneurysm repair, EVAR, that can be used for treatment, surgical procedure for repairing this type of aneurysm. Now there are different type of aneurysm: true, false, infected, and dissecting aneurysm. True aneurysm is all the three layers of the vessels are involved. Okay, intima, media, and adventitia. When all the three layers are not involved, then it is false aneurysm. Infected or mycotic aneurysm are false aneurysm, and dissecting aneurysm means dissection with aneurysmal dilatation of false lumen is known as dissecting aneurysm. So, four types of aneurysm. Other aneurysm are fusiform. They are actually based on the shapes of aneurysm. Fusiform, saccular. Barrier aneurysm is most common type of brain aneurysm. Uh, when there is rupture in the circle of Willis and the rupture causes subarachnoid hemorrhage, it can cause. There are other a type of aneurysm based on their location, like intracranial that we have just discussed, then thoracic, abdominal aorta, renal, iliac, femoral, and popliteal. Okay. Now next condition is Takayasu arthritis. It is also known as aortoarthritis or pulseless disease. Student, there are two more topics left. I think we should discuss it in the next class. I'll be taking a YouTube session on venous disorders. I think on 27th of November I will be taking venous disorders, and I'll continue with Takayasu arthritis, and one more topic is left, that is known as giant cell arthritis. So Takayasu and giant cell arthritis I will discuss in venous disorder. I'll start with Takayasu and giant cell arthritis, and then we will move on to venous disorders. So day after tomorrow I'll be taking venous disorder. There I will be discussing these topics. And on Unacademy, just download the app if you have not downloaded. On Unacademy I will be taking free special classes that are absolutely free. You can attend it, and at 8 o'clock I will be discussing few important MCQs from high yield topics. Okay, so at 8 o'clock I'll be there. Today at 8 o'clock on Unacademy I'll be there. We'll be discussing few important MCQs from high yield topic, and tomorrow morning 9:30 a.m. in the morning I will be discussing few more MCQs. Okay, so I'll be discussing a series of MCQs from high yield topic in coming days. So just download the Unacademy app and you can attend these classes. They are absolutely free. If you have not taken subscription, then you can take to attend the theory classes, and if you have not taken, you can attend special classes as well, there where I will be discussing MCQs. Okay, so see you students in the next class today on Unacademy 8 o'clock. Okay, take care, bye bye.